Hey guys, welcome to EMS Challenge. We're at BREMSS today. If you're in the area, come out. We got lectures from 9 to 11. At 11, we're actually going to have a presentation from a cardiac arrest survivor to a crew at a Pelham. Then we'll do lunch, and we have skill lab this afternoon. If you still need ACLS or PALS, we can check you up on that. Just give us a heads up. Remember, next Wednesday, we're doing a bonus edition. We're making up from a cancellation we had to do back in the winter. We'll be at Talladega Super Speedway next Wednesday from 9 to 11 and doing skills there. And then the next Wednesday, we're at Prattville. So August is a busy month. I will also post before lunch today the Cadaver Lab. Cadaver Lab, free for EMS providers, be August 29th and 30th. So Thursday afternoon and all day Friday at Volker Hall. They are doing remodeling at the med school. So you have to enter from the back, and I'll put directions on the webpage for that. So, all right, thanks for almost smiling, and we'll get Dr. Rushton up here and get him started. Thank you, sir.
Hello, and thanks for having me. My name is Will Rushton. I am over at both UAB and Children's, and I run our State Poison Center as well as our Office of Medical Toxicology. It was kind enough for you guys to invite me here to talk about something that I'm very passionate about, which is sort of our, this is southeastern snakes, but it's really sort of, what snakes are up here in the area and what do we need to watch out for. And I'm glad I got to go first because I think we're going to spend the first couple of hours talking about some DNA, some molecular basis of venom components, talking a little bit more about covalent bonds, and maybe by this evening, we'll get into some management strategies and wrap up sort of later tonight. And all seriousness is, the reason I actually wanted to come today is we're actually doing some really, to be frank, really cool things over at UAB and Children's. If you went around the country right now and you asked, what are the top 5 snakebite programs in the United States, is we would easily be up there, and probably people would name us in the top 3. And some of the things we're going to talk about is we're going to gloss over a little bit of the research we're doing, but I really just want to show some of the new sort of innovative programs that we have here. For those people that actually showed up, I actually brought a lot of swag, and we have all these snakebite posters that we way overprinted. So if anyone wants them, I keep trying to go around elementary schools and hand them out as much as possible. I will say my only financial disclosure, I do sit on this on the monitoring board for this sort of multinational trial about a new antivenom is coming up, but that's not anything we're going to talk about today. I was just informed I need a new intro photo because I guess I've been using this one photo for probably going on 8-9 years. But I always like to start with this because there's just something inherently wired in us that, when we see a snake bite is, humans are just, we're programmed to fear it. And there's just a lot of heightened anxiety that goes with snake bites. So, they say if you give an hour talk that at best people might remember 3 things, but really they're only going to remember 1 thing. So I guess really my overall one thing is, reassure people, particularly parents of kids that get envenomated by snakes, like you're going to be okay. In the United States, we now have the technology and the expertise to take care of snake bites. And with extremely rare circumstances, is people are not going to die. People are not going to lose their fingers or toes. Internationally, it is different. WHO does say there's up to 200,000 deaths a year by snakes, but those are not in the United States. We see anywhere between 2 to 6 snake bites deaths a year. And again, these are always just sort of, wild circumstances. I'm trained both as an ED physician and as a medical toxicologist, but my medical toxicology, I have these nemesis out there, and this is Dr. Axe. He's this sort of anti-Western medicine, anti-science person. Does a lot of sort of holistic medicine, and I was surprised to find out he actually had a book about how to treat snake bites. And great thing about the internet is you can find them as anything, and that's what Dr. Axe says. Let's see if I guess none of these pointers work for the people that are live streaming in. But I like Dr. Axe because he says for a rattlesnake envenomation, doctor may order an ECG. I mean, I guess we order ECGs on everybody now. You come with an ankle sprain to our ED working at an ECG on you. But if you may need a head CT if you come in with altered mental status and confusion. Well, that's not really applicable to a snake bite, but sure, I guess so. But notice what he sort of ends here is a surgical procedure where the fascia is cut may be necessary. And if you remember a second point about this talk, is we need to do everything we can as a medical community to keep snake bites away from surgeons. This is definitely recognized, probably 2000 was sort of the turning point. In the 90s, up a little bit in the early 2000s, is thought that snake bites were really sort of more surgical pathologies, that all these patients were at risk for compartment syndrome. That has really changed our understanding of, sort of the molecular basis of snake bites and animal studies that came out. It's not really true compartment syndrome that patients get. Plus, our antivenom technology, starting about 2006, took leaps, forward. And so we really have this new generation of antivenom. We'll talk more about that later. But as a medical community, and this is where I'm going to come back to as sort of my ask, to you guys to think about it. When trying to consider, where is maybe appropriate centers, we want to take patients to places that see a lot of snake bites. And we can sort of talk about what that may mean at the end. But in general, is not a surgical pathology anymore. We try to do everything we can to keep away from surgeons. I do like for the cottonmouth water moccasin, as Dr. Axe says, you got to be careful because they may develop something called tachycardia. He was the one that put this in blue, not me. I guess is the big, complication you worry about. And finally, the end here with copperheads, he says, hey, copperheads aren't that bad. You sort of wash the wound and discharge them. And absolutely not. I feel like some of the worst wounds we see here and persistent morbidity that we see in Alabama really come from untreated copperhead bites. I'm going to go through this next part a little bit quickly, and because the next couple slides are really just sort of an overview about sort of the snakes in this area themselves. One of the reasons I'm gonna go through this a little bit quickly is, number one, is I always try to tell people is, when I give a talk is, I'm an expert at snake bites the human body, not snakes themselves. We're lucky in Jefferson County that we have great partners that are actually our snake experts, both at the Birmingham Zoo and Rushton Mountain, which we do great sort of co-education, a lot of collaboration with them. I'm also going to do this quickly because I've talked to EMS groups before, and I found out that a lot of people in this audience probably know a lot more about the snakes themselves than I do, and I don't like to embarrass myself in front of you guys. But in general, when we think about sort of the 6 venomous snakes in Alabama, and that's going to be sort of your eastern diamondback, your copperhead and your cottonmouth, your pygmy rattlesnake, your timber rattlesnake, and then finally there's the coral snake. The coral snake envenomations are thankfully so rare. In the 9 years I've been here at Birmingham and through the state's poison center is, we actually cover all the snake bites throughout the entire state. We've had one clinically sort of relevant coral snake bites. In general, we're just very lucky that coral snakes themselves are just not aggressive. So really the bulk of this talk is actually going to be talking about the North American pit vipers. And when you think about North American pit vipers, is the genius for it, the taxidermy is Crotolinae, and Crotolinae just means, the subfamily for it is Crotolinae, and that just means North American pit vipers. Underneath that is we actually divide them up into crotoless species, which are going to be rattlesnakes, and echistrodons, which are non-rattlesnake pit vipers. And the non-rattlesnake pit vipers are going to be your copperheads and your cottonmouths. And so you may hear, as we sort of talking about in our common lingo or common vernacular, is a crotoless bite versus an echistrodon bite. And that's actually kind of important to us because an echistrodon, again, it's going to be a copperhead or a cottonmouth, causes a lot of really bad severe tissue damage. And we see a lot of really sort of localized ecchymosis, bruising, some really bad sort of blood blisters, these hemorrhagic bullae I'll show you guys some photos of, but does not cause systemic coagulopathy. Whereas the rattlesnakes, again, the crotoless species, we do have to worry not only about the tissue damage themselves, but sort of the systemic sort of drops in people's platelet counts and fibrinogen and things like that. And so when we're sort of discussing, among ourselves is, how do we treat? We do have slightly different approaches to like a crotoless bite, again, a rattlesnake bite versus a echistrodon bite. I think for the people in the audience that may know a lot more about snakes, someone invariably puts their hands up and says, what about the pygmy rattlesnake? Yes, the pygmy rattlesnake is also a rattlesnake. It does not start with crotoless, so that is one of the exceptions. But this is the timber rattlesnake, which is also the same thing as the canebrake rattlesnake. And the picture here, I guess, on everyone's well, my left screen, I guess most people's right, is from the Birmingham Zoo, which actually has an albino timber rattlesnake, which I did not know exists. They also have a different snake out there that has arthritis. They've stapled a fentanyl patch to the back, which is absolutely fascinating. Like I said, is like you want to talk about the real snake experts, like I would go to the Birmingham Zoo. Again, Crotalus horridus horridus is just sort of the Latin name for the timber rattlesnake. And this is actually one of my partners sent this to me, just from Oak Mountain. I guess our sound's turned off, but you know, if the sound was on, you hear just this very sort of stereotypical loud rattle sound. The other rattlesnake, or probably the second most common rattlesnake I get called about, is going to be your eastern diamondback. And again, these come from the Birmingham Zoo. They tend to name all their snakes. So this snake was named Daryl. Unfortunately, Daryl just recently passed away, I think about a year and a half ago. And they had a big ceremony for it. But this is the eastern diamondback. Now, natively in the state of Alabama, the eastern diamondback is really in the southern part of the state, maybe about as far north as Montgomery. That being said, we still see a fair number of eastern diamondback envenomations up here. Number one is because we get transfers every place. But the second reason, and probably good for, I guess, this crowd to know about, is people love to keep eastern diamondbacks as pets. I don't know why. It's actually a very dangerous snake. I see Dr. Ferguson in the back. He's giving me the thumbs up. I think he wants an eastern diamondback. Yeah. For whatever reason, eastern diamondbacks tend to be a very popular sort of snake pet. Of the rattlesnakes, this is by far the worst one, which we could talk a little bit about if we have time. But the eastern diamondback in particular causes just a lot of really severe coagulopathy that unfortunately can last up to 2 weeks after the venomation. So we just keep people in the hospital for a very long time, giving them very expensive antivenom. And then sort of transitioning now to a Chistrodon, so Chistrodon contortrix, this is going to be your copperhead snake. Again, a Chistrodon non-rattlesnake pit viper. People love bringing in snakes to the emergency department. I imagine they probably try to bring them back into your ambulances all the time too. I love this one on the, this is a picture of me holding a copperhead snake or a dead copperhead snake that someone brought in at 3 a.m. Because what I find too is when hospitals transfer us patients is they usually transfer the dead snake with the patient. And this really confused me for the longest time, because in this scenario, I went into, this is one of our beds at UAB, went into this room, saw the patient, went through their paperwork, which the hospital was kind enough to send with us. And then there was just a Kroger shopping bag, and I opened up the Kroger shopping bag, and here was this dead snake. And this happens over and over again, not, both to transfer at UAB and to Children's. For the longest time, I was like, man, why are we just getting why is, these hospitals feel the need to send like a dead snake? I mean, you could also ask, why do patients feel the need to bring it in? But they probably still think that we need to identify them, which we don't. But I realize that no one knows how to discard of a dead snake once they enter a healthcare facility. It's not true biomedical waste. You can't really just toss it in a trash can. And so hospitals don't know what to do with it. So like, well, sitting the patient, we might as well just send the snake on with them. Sort of a tale as old as time. But then on the other side of the screen, this is sort of a live copperhead. This is, again, us doing an educational program over at Rushton Mountain. Also has very intelligent herpetologist, snakebite expert. This is actually Aaron, and last time I actually gave this talk to EMS Challenge, someone actually knew him, is that's actually a live copperhead inside this glass tube. And what you don't see behind him is because there's all these snake protocols, is there's Siobhan, she's another snakebite expert, is actually sitting right behind him holding out snake tongs. So that case, if he drops it, they can quickly sort of neutralize the snake. And then let's see here, just, another copperhead over the Birmingham Zoo. And then finally, the last snake I really want to talk about that's sort of germane to this area is the cottonmouth snake, or the Chistrodon pisciferus. It took me a couple of years to learn how to say the word pisciferus, which really just means eater of fish, because it's going to be your cottonmouth and your water moccasin as the same snake. The snakes we see, this seems to be the one that causes the most tissue damage in this area. In fact, as soon as I leave you guys, I need to book it back over at Children's, because we had a cottonmouth envenomation that came in late last night that we're aggressively treating with antivenom this morning. At the Birmingham Zoo, they have all sorts of signs up there saying, please do not antagonize the animals. Please do not tap on the glass. Please do not tap on the glass. So I hate to show you this video, because someone actually tapped in the glass and sent it to me, but it's a pretty great video of sort of what it looks like when a cottonmouth strikes at you. This is one of those things of don't ever do this, but look what happens when you do. You see right here, this cottonmouth sort of going in a strike position, and then you'll see this very sort of classic strike, and you see where it gets this cottonmouth name here. There you go in a second. Now, in the state of Alabama we see way more Echistrodon bites, again, non-rattlesnake pit vipers, than we see rattlesnake envenomations. And this is really the same throughout the Southeast United States. I used to say that, you know, the Echistrodons had rattle envy. That's why we see a lot more of them. But really, actually, talking to more of the snake bite experts, it has to go with, you know, if a rattlesnake wants to warn off a larger predator, aka us, that they're there, what do? They shake their rattle. For the Echistrodons, since they do not have a rattle, you know, they're actually biting us not to eat us, but they're warning that they're there as a defensive bite. And that's just sort of because they don't have that rattle, the only way to let us know that they're in the vicinity is to give that bite and then slither away. So we get about called into our state poison center, and almost all snakes in the state of Alabama get called into the poison center. Almost every year, about between 200 and 250 snake bites a year in this state. 80 to 85% of those each year are Echistrodons. Only about 10 to 15% of the bites that we see are actually rattlesnakes. Now that differs dramatically in the Southwest United States, where for them it's 100% rattlesnake bites. So it's one of the reasons if you're ever trying to read snake bite literature or even read guidelines about snake bites, there's a fair amount of geographic variability that goes along with it. And we all sort of recognize it among ourselves. So if you're ever reading sort of pre-hospital guidelines from, say, Arizona, which is another one of the sort of well-known snakebite programs in the country, is just know that their guidelines are going to be, you know, pre-hospital, are going to be a little bit different than ours, just because they're going to be a lot more. They're going to be a lot more worried about rattlesnake envenomation and potentially systemic coagulopathy. When for most of the time, what I'm worried about with our snake bites are going to be, you know, tissue damage, but really severe tissue damage that we see. It is just helpful to know about these two other snake species. These are in the Southwest United States. This is the Crotalus atrox. This is the Western diamondback, and this is the Crotalus scutulatus, which is the Mojave rattlesnake. The Western diamondback also tends to cause a lot of really severe systemic coagulopathy, and the Mojave rattlesnake is the only North American pit viper that actually has a clinically relevant neurotoxin with it. Because of that, is the most common antivenom that's out there is Crotalide polyvalent immune FAB. Its trade name is Crofab. It's the most commonly commercially available one, and it's made or derived from the four snake species: Eastern diamondback, Western diamondback, because they tend to cause the most severe coagulopathy. The Mojave rattlesnake, because it will actually treat sort of this neurotoxin if you get envenomated in the Southwest, and the cottonmouth. So there is actually an Echistrodon species that goes into making it. And because of that, we say that that antivenom is actually sort of gives you protection against all North American pit vipers. So the two commercially available products on the market is we can actually use for all pit vipers, so they're FDA approved for all pit vipers. So at least per the FDA is you don't have to choose a different antivenom based on a Echistrodon versus a Crotalus species. That being said, I think we're doing a lot of research and a lot of other programs are, and we may choose different antivenoms. That's going to be sort of more on our end. And we'll probably be a little bit more aggressive about the initial dose. If it's a rattlesnake bite, I tend to give 1.5 times the dose up front that I would normally give to a non-rattlesnake pit viper. Everyone always likes to talk about, I think, the venomous versus non-venomous, how you do identification. Again, I hesitate to wade into this because, like so many things, this gets taught, but this is not necessarily true because you talk to the herpetologists at the Birmingham Zoo and Rushton Mountain, and they say, yeah, venomous snakes, again, North American pit viper, supposed to have this more triangular shaped head, these slit-like eyes. If you were stupid enough, or in our snakebite population, intoxicated enough to get close to a snake a venomous pit viper, you would see they have this heat-sensing pit. This is difficult for a couple reasons. Number one is there are some snakes in Alabama that will mimic this. I think notoriously the hognose snake will try to flatten its head to look like a venomous snake. And if someone is going to bring you a snake to identify it, what's the most common way they bring it in, presumably is dead, is they take a blunt force object and they bash its head in. So everything we've talked about, we just lost. Probably the more helpful thing is if you flip over the snake, North American venomous snakes distal to their anal plate, it's called a cloaca, have a single row of plates, where non-venomous snakes in North America have a double row. And here's actually a picture of that, of a snake that was actually brought into the emergency department. You see here clearly a single row of plates at the very distal end of the tail. You could also just look over the patient and realize, hey, this person's leg swelling up. This is definitely a venomous bite, which is why, our recommendation is we do not need the snake to make an identification. Please do not bring snakes alive or dead into the back of an ambulance or the back of the or into the hospital. Snakes are cold-blooded animals, and so ideally they sort of interact with humans when it's about 80 degrees Fahrenheit out, which means that usually a snake envenomation over the summer is going to happen in the evening. If you actually look at our data, that's exactly where this comes up. And we really see a bimodal range here in Alabama. It starts about March, goes through beginning of July, and it'll take over. And then from July through mid to late August is we see a dip in numbers. And then towards late August, throughout October, is our numbers will go back up. And it's probably, again, during sort of mating season as well as the temperature getting low. We're almost about mid-August, and we actually had 3 snake bites got called into the snake poison center last night. This is sort of like an epidemiology of snake bites, and for those of you who have taken care of patients, particularly adults with snake bites, as you may relate with this, this is a study that's actually done rattlesnake bites out of Arizona in the late 80s. However, I feel like every couple of years people try to replicate this study with very similar results, because it's a predominantly, particularly in adults, a male-derived pathology. There is a very high association with alcohol use that goes with snake bites. Again, North American pit vipers, they're not trying to eat us. When they do bite us, it's almost always a defensive bite. So if they have the option between biting us or getting away, they're going to try to get away unless you're intoxicated and you go and try to pick up the snake. And that's why in this study, they actually try to classify this legitimate versus illegitimate bite. And legitimate bite means, were you actually innocent in this and then you got envenomated? Versus an illegitimate bite means, did you do something to go and antagonize a snake? And upper extremity bites tend to be very highly associated with illegitimate bites, meaning that someone went down and picked it up. If you see an upper extremity bite or someone complains of upper extremity bite, always ask them about other bite sites, because what I find a lot is the upper extremity bites tend to be intoxicated men. They pick the snake up, usually their dominant hand, they get envenomated on their contralateral arm. I think sober, rational thing would be drop the snake, flee the area, but instead they try to wrestle the snake. So there's an upper extremity bite. It's actually fairly common, even in our own data, that we see just a lot of multiple bites. So I'd usually inquire about those as well. I think if we were going to do our own study about this, about who exactly is getting bit by snakes in this area, there really seems to be about, grossly 3 different populations. There's kids, and we see a lot of pediatric snake bites. The good news is kids just bounce back from snake bites very quickly. In fact, it's sort of one of the highlights of my job is I get to go in and tell parents their kid's going to be okay. And parents just have all this anxiety about, I look like the hero, but I really don't do anything, just because they're young and they get better on their own. And then particularly in this area, I see a lot of gardeners. And these are usually sort of the upper extremity bites, I would say legitimate. People are gardening, particularly around Mountain Brook, Vestavia, have a fair number of both copperheads and timber rattlesnakes. And people often are just not wearing gloves. They get envenomated. And then finally, our third category is absolutely just that intoxicated male category that you just see those people coming in. I'm like, well, what happened right before you got bit by a snake? He goes, well, I told my friend to hold my beer. That sort of scenario. And so in general, I think if we're going to put our patients around here, would be sort of kids. It seems like frog hunting or toad hunting is big for kids in this area. Well, also it turns out that copperheads are also frog hunting as well. But kids, gardeners, and intoxicated people. Notice what I didn't say there is hikers and runners and like mountain bikers. We actually very rarely see people that are actually just out there hiking or happen to be running by a snake. Again, is because these snakes, these are defensive bites. So if you're moving, they don't want anything to do with you. It's more the stationary people as well. This is just us over at the Birmingham Zoo, just sort of doing one of our educational programs with them. Why do we care about snake bites? In general, three, I would say distinct, although there's some overlap, sort of pathologies we worry about: local tissue damage, coagulopathy, and then the neuromuscular blockade. The last one is not really appropriate for us because that's really going to be the Mojave rattlesnake that's going to be in the Southwest United States. So really, I'm going to just quickly mention sort of the first two. This is a very mild copperhead envenomation right here to the forearm. Because the way that the snakes go out and hunt is they go and they find their prey. We'll just say it's a nondescript rodent. They actually bite the rodent, inject its venom, and then they let the rodent flee, and then they follow its pheromones, and then they go and eat it. So with the echistodons, again, the non-rattlesnake pit vipers, I keep saying there's no systemic coagulopathy, but there's absolutely localized coagulopathy. And by that it means that you sort of see this area bruising that often to me looks like the same size as like a rodent, a frog, or something that the snakes might actually be hunting. So this is a very mild envenomation. This is a 7-year-old kid from, you want to say last year. This picture is probably now a couple of years old as well. So this is a 7-year-old kid that got envenomated here on their calcaneus, developed these hemorrhagic bullae, which are very common with both copperheads and cottonmouth envenomations. And they actually got taken to a smaller hospital initially that just does not see that many snake bites. And so I got called about this from their emergency department. And then I got called about the surgeon saying, hey, this kid got bit by a snake. They have necrotic tissue over their calcaneus. We're taking to the OR to do a debridement. I said, absolutely, please do not do that. This is actually not necrotic tissue. I promise you, this is all just ecchymotic, blood that's underneath sort of that skin right there. Do not take this kid at all to the OR. This will just be a disaster. You will never get that, to stop bleeding. And again, this is not necrotic tissue. So we were able to actually, thankfully, and that kid got them up here to Children's, got Envenom, and that kid walked out of the hospital 36 hours later. This is just sort of another sort of classic sort of bite to the hand. You see right here, sort of at the bite site, is there's just a lot of persistent blood oozing. I guess actually no one can see that. But you see right there sort of that distal index finger where you see sort of that bluish area. It's just the bites just tend to ooze for like hours, sometimes up to 24 hours. And you see just more sort of these blisters pop up. The next actually slides get a little bit more impressive. So I just usually like to warn people. But this is actually from this year. And this is another kid that we saw from another copperhead bite. So again, there's this folklore out there that copperheads bites are just completely benign. You don't need to do anything with them. And I'm here to tell you is we see some really bad copperhead bites in this area. I'm going to circle back to this kid because this is one of, what I want to end with is some of the new things we're doing here is this is a really bad hemorrhagic bullseye. I think everyone that looks at this takes a internal deep breath and it's like, oh my gosh, this looks terrible. Is that kid at risk for losing their finger? Thankfully, we've now developed the experience and we know how to deal with this. Many places are not going to know what to do with this. They're going to try to get hand surgery involved. They tend to get put on antibiotics, get all sorts of debridement. We actually do needle aspiration. We give them antivenom. We give them needle aspiration while they're in the hospital. And after we needle aspirate, they almost, I'm looking at the mouse. Well, here on, I guess my left, everyone's looking at this computer's right, is you get this very boggy skin. We then actually leave that skin intact when they leave the hospital, and we bring them back to the clinic a week later, and then we actually go ahead and debride the skin off at that time. We leave that skin intact when they're still in the hospital, just acting sort of like a biological shield. We're actually having great outcomes doing this. But I think this is, again, something else that if you're not here or you're not around someone that's used to seeing these, is there's a lot of different unfortunate routes I think you could have gone with this kid. But again, this is certainly an extreme example, but it's not that extreme. We probably see about 10 of these hemorrhagic emboli a year that look this bad. They do tend to be more in the hand. Copperheads and cottonmouth bites, the hands tend to really cause these. Obviously, if you're intoxicated and you pick up by a snake and you get bit on your neck, you could get some local tracheal swelling. And we talk about more systemic coagulopathy. This can be more sort of untreated rattlesnake bites. I think you look at this and go like, that's not just localized coagulopathy. Really don't want to belabor this point too much, but except to say we just don't understand snake venom that well. You know, the black widow venom, we know so much about that because that's just one neurotoxin the black widow is injecting into humans. We know exactly how it works. We know what it does. When snakes sort of bite mammalian tissue, is they're injecting hundreds, not different thousands of different enzymes and vasoactive peptides. And it's frustrating because the venom components differ among snake species, but they'll also differ among the same species in different geographical areas. And that's why it's sort of this big unknown as really we're trying to sort of tease out, you know, what does what. So what's the really big thing we worry about with rattlesnakes? Well, two things. Number one, there's VIT, which is going to be venom-induced thrombocytopenia, which is going to be platelet destruction. But the really bad one is VIC, V-I-C-C, which is venom-induced consumptive coagulopathy. And this is, unfortunately, I did all my training in Virginia. So this is in the late 2000s, someone that was actually at a Pentecostal church where they used Eastern Diamondbacks to speak in snake tongues, got envenomated, would have lived if they sought healthcare immediately. Unfortunately, they decided to pray over the body for about 48 hours. And this is one of those, you know, 2 to 6, you know, U.S. snake bites a year. Like I said, these are all sort of extraordinary circumstances. Unfortunately, ended up dying, just sort of massive bleeding out, internal bleeding, and hemopericardium. Just to hear, just if anyone wants to talk offline about this, I'd be more than happy to waste hours of your life. But we're doing a lot of work at UAB is using some of these newer coagulation pathways like thromboelastograms, both to predict rattlesnakes, but also to look at antivenom responsiveness. We've had a fair amount of success actually publishing on that, really trying to be better antivenom stewards, just because antivenom is very efficacious, but it's also incredibly expensive. So trying to sort of walk that balance. I will say is I keep emphasizing the Mojave rattlesnake is the only snake that has that clinically relevant neurotoxin. But actually all the rattlesnakes do have a little bit of localized neurotoxin. This is a little bit subtle to see. Hopefully people can see some of these fasciculations. This is a nurse practitioner at Sylacauga sent this to me one time, but this is called actually myokymia. It's sort of Greek for like bag of worms. It's just localized muscle fasciculations. I find a lot of times rattlesnake bites will also say, hey, I just feel like my arm is spasming. If you see this muscle fasciculation or someone says my arm is spasming, just know that's actually going to be a rattlesnake bite and not an echistrodon. And that would be very helpful information to pass along and report, because that is actually going to help us not necessarily choose our antivenom, but really choose our starting dose and really how frequent we're going to do labs. So my buddy, again, Dr. Axe, has a lot of recommendations about how to treat snake bites, which turns out it's a lot of essential oils. So I think for the sake of time, I'm just going to skip over this and say, this is not what we recommend. So pre-hospital care, and I understand this is the difficulty coming and talk to you guys, because really the best thing you can do pre-hospital is really get them to a healthcare facility as quick as possible. I'm going to show you some measurements. If you have time to start doing some snake bite measurements, that would actually be incredibly helpful, particularly if they're going to other outlying hospitals. This is actually published in 1968 as sort of a pre-hospital guide, and it's a great guide now of what not to do, which says apply a tourniquet. Absolutely not. Like I said, I worry way more about the local tissue damage from our snake bites than I do about any systemic toxicity. Please do not capture the snake and kill it. Please leave the snake alone and sort of flee the area. And please do not apply incisions to the fang marks and apply suction. It's sort of crazy. And another thing is cryotherapy means don't put ice. You know, what's basic first aid? You see a swollen joint, you put ice on it. Ice is good for every swollen joint probably every swollen joint except for a snake bite. It tends to cause a lot of your blood vessels constriction and will really localize that venom. And particularly if they were bitten on the fingers, I'll show you guys in a second. These are one of the few times I have seen people actually lose their fingers, so they just got sort of plunged in an ice bath. It's sort of crazy here in 2024. I have to say, hey, please do not hook your friends up to a car battery and shock them after they got bit by a snake, which happens way more frequently than you think it would. There are these venom extractors. I don't know if anyone's ever seen these. These are a waste of your money. They're incredibly expensive. They come with a tourniquet, which we don't like to use, obviously. And then they come with this razor. Obviously, the idea is to shave, I guess, people's arm hair off. Snake bites are just so painful. Like even just you put the heat of your hand, near someone's bite, or when I go to do measurements, they're like yelling at pain. I cannot imagine taking a razor over someone's bite site. A very anti-violent person, but this might be a good reason to push someone away very quickly. When they come into the hospital, we're just going to update their tetanus. There's no need initially, unless someone's actually having an allergic reaction, to give them steroids. I did want to talk about quickly how antivenom works. Again, this is going to be the more common type of antivenom that's out there in the market. There's 2 commercially available products out there. This is quetilytic polyvalent immune FAB, colloquially known as CroFab. And so there are these technicians in Salt Lake City that milk the venom from 4 species: the eastern diamondback, the western diamondback, the Mojave rattlesnake, and the cottonmouth. I used to think that was sort of like a terrible job, and then I found they have like a waiting list of people that apply for that job each year. And they take that venom. I guess it's probably not Dr. Ferguson. For everyone in the audience, he's scowling at me back there when I said that. And so then they take that venom and then they fly it to Western Australia and they inject it in sheep. And why Western Australia was the only place I know for sure has not had mad cow disease. And then they take the sheep antibodies, the sheep IgG, which is what this is showing, and then they fly to the company's headquarters, which is in Wales. And then in Wales, what they do is they just take let's see if I can get this to work. Oh, I guess it's not showing up here, but basically they take that part where it says just the FAB at the very top, and they actually cut that off from the rest of the antibody, because that FAB part is the part that's really specific for binding up the snake components. So when we're injecting antivenom, what we're doing is just giving just that very small FAB amount. What this has done, and it said this is sort of the newer generation of antivenom, and this came out in market about 2006. The other commercially available Antivib came out in 2021. It's very similar idea. Is prior to this is, what was antivenom made of? Is, well, we were just taking venom, putting it in horses and taking horse antibodies, injecting them into humans. Had a very, very high rate of anaphylactic reaction. And that's why people that are used to treat, that trained in the 90s, early 2000s, when they say they have a lot of hesitation giving antivenom, well, it's because they're still thinking the old Wyeth antivenom. But really, in the mid 2000s, as our antivenom technology took dramatic leaps ahead of time. You have to be careful, though, about when to give antivenom, because this is called the United States algorithm for North American pit vipers. Unfortunately, this was very industry funded, and you sort of get in this loop where you see here, if you have persistent pain or persistent swelling, you keep doing more and more antivenom, which is what the companies want you to do. I personally actually hate this. The antivenom companies have this poster, and they love to put it up, in every single ED they can in the state. I keep going around and ripping them down. In Alabama, there are these recommendations that I have these. Anyone's actually interested in them. This is actually what we send out to, all the hospitals throughout the state. We try to focus a lot more on objective measurements. I'm going to show you. We try to do these circumferential measurements, and we try to that way. So at least we say, hey, when are we truly getting control of the swelling? I think these are actually much better guidelines. I fully support them, and it's not just because you look in the bottom right corners. I'm the author of these. So we talk about circumferential measurements, and this is something, if I know how busy you guys are back in the squad, but if you ever have time to go ahead and get this started, this is actually incredibly helpful, because this is one of those things that, like, a picture tells 1,000 words. For some reason, it is very difficult for me on the phone to try to explain to ED providers how to put a tape measure around someone's extremity and then mark both sides of it. But when we talk about circumferential measurements, this is really the best way to figure out if we're getting sort of if we're getting control of that snake bite itself. Because what happens is you get this lymphatic insufficiency. So what that means is people move their arm, even once we've gotten good control in the envenomation, that swelling is going to move up and down. In fact, I usually prefer that if we don't think it's a rattlesnake bite, to actually elevate the extremity. Somewhat controversial. Everyone has a lot of opinions about it. That will help improve their pain, but that will pull the swelling down into the forearm. So you'll notice the swelling in the forearm will get worse. And for us, that's not a reason to get more antivenom. That's why the way we wrote our guidelines, that's more of the natural sort of healing process. And that's, again, why we do these circumferential measurements, put a tape measure around every major joint that might be involved. So if they're bit on the hand, put a tape measure around proximal distal to the wrist, and then do good measurements. These are the measurements then that we continue inside the hospital. This is from my snakebite service. Is there like a EMS equivalent to like a medical student gunner? Someone that does a little bit overly aggressive treatment. You do not need to do this many markings. This is too much. But really, it's just sort of the markings are correct. It's notice really just proximal distal to every joint. This is something that's a lot more appropriate, and this is actually how we'll fall in the hospital. If this is something we could ever start, pre-hospital wise, again, as I spend a lot of time trying to tell people, hey, just put a tape measure, around their extremity and mark both sides. You would not believe sort of the crazy markings that then when I finally go see the patient, it's like these dotted lines or these arrows, or sometimes they tell me they have a circumferential measurement, but they're giving me as by 3 by 4 centimeters. I'm like, I think you just gave me a rectangle, which does not make any sense. Again, these are just from our own clinical practice. You know exactly what these measurements look like. These are unbelievably helpful. The reason I keep harping on these, that if we do these measurements and we do them right, is we save at least 6 vials of antivenom. Each vial is $5,000, that's $30,000 of antivenom, and a night in the hospital, because you have to watch them usually 12 hours after the last dose. So what we found in our program, and we really push it, is that, again, the hospitals I cover through the Poison Center, is we're fairly aggressive about early antivenom. For us, early antivenom is within 8 hours. If you're doing good measurements, we stop all antivenom after that and just watch them clinically. But the hospital has to be doing sort of these good objective measurements. If you get them to UAB or to Children's, I have a lot more control over there, and I actually do training both on the nursing side and the physician side, as Dr. Anderson in the back can attest to. So pitfalls, don't put it in, again, ice. This is unfortunately is one of the few people that lost their fingers. He got bit by a copperhead. He plunged his hand into an ice bath for about 30 minutes, and then this is sort of true necrotic tissue. So in my last 10 minutes I have here, is I really want to focus on, again, what is my ulterior motive for coming here? And I want to talk to you guys about some of the things that we're doing at UAB. If anyone wants to talk about, we are doing this coagulation studies, be happy to talk about it, but for time's sake, as I decided to skip over that. But there's a couple of different initiatives that we're doing. Is a couple of years ago, is unfortunately right at 2020, is we realized we're just doing a terrible job of post-hospital snakebite care. Insofar that people are getting antivenom, they're being discharged, they had no place to follow up, they're being told, I guess, go see their primary care physician if they have one, which is a big stretch in Alabama. And primary care doctors are sending people back in droves back to the emergency departments to get like DVT ultrasounds. They were getting put on antibiotics. They were getting put on steroids. They were being referred to surgeons for these like aggressive debridements that we really did not want them to do. So we sat around and said, hey, we really should come up with this idea of how can we do this better? And what we started is in our program is actually we have now our first in the nation dedicated snakebite follow-up clinic, where every single snakebite in the state of Alabama is offered, a follow-up appointment. Of course, they have to come to Birmingham. That doesn't matter as much for us, but more so when we cover this the bites down in Mobile. But we'll see them all sort of a week out. And what we do is we sort of assess for range of motion activities. And we look to see if they had this hemorrhagic bullae. We'll repeat their labs because I mentioned that VIC, that venom-induced consumptive coagulopathy, can recur up to 2 weeks. So it's really bad if someone drops their fibrinogen again and we don't realize it. And then finally, we can treat sort of a lot of persistent swelling. We got somehow a fair amount of positive publicity about this. We actually got a letter in the New England Journal of Medicine, and then got these fancy websites. I work at both children's and UAB, which is interesting because the buildings are physically connected to each other, but somehow those two hospitals just do not get along. So I work at both of them, and my program's at both of them, but they have to each have their own website, which is the exact same know about it. So we started this, and we actually had a lot of really positive publicity. For the people that are in the room, I don't know if I'm showing up on camera or not, but we actually even, our program created these like snake bite books, and these are for people when they get envenomated. So the very beginning is just sort of some blatant propaganda about us that I wrote. The next couple of pages are actually information about the snakes that we see here in Alabama. These are actually designed to be as coloring books for kids, and then we realized that adults really like these as well. So I stopped handing out the crayons to the adults and just give the books as well here. But it has some like what to do, range of motion exercises, but then the back too also just sort of really highlights the fact that we had this clinic, this first in the nation clinic, which now other programs across the country are actually copying our model. But this snakebite program, and like I said, let me just, this is actually what goes around to every single snakebite in the state, because our specialists in poison information, they have this cool name called SPIES. We used to call them Poison Information Specialists, but then we found out that that acronym did not work nearly as well. So now they're specialists in poison information. They go ahead and talk of our clinic and then give people sort of this ability to follow up with it. It's been amazingly successful. Like I said, we want to start this in 2020. I think world events got in our way in 2020. So we started in 2021, and we've now seen over 100 people in our clinic. One of the fun things about doing this is I get to come and talk to people and take credit for it, but there's just an abundance of people that have gone into this. Like, physical therapy has written both their inpatient and outpatient own order set for what to do about snake bites, both at UAB and children's. These are just some people that are sort of involved with it as well. And then for our clinic, we actually took our algorithms and we actually got them published nationally so other people can follow them. And I'm not going to go through the algorithms themselves. I'd be happy to share if anyone's actually interested. But the idea is that we're actually trying to approach this in an objective and scientific manner. It's not just like people show up and we're like, hey, it's cool as a snake bite. Let's just try to figure out what to do. We sort of sat down as a group between wound care physicians, toxicologists, pharmacists, physical therapists, and said, hey, how can we do this better? And then it's actually pretty fun seeing kids. And I think I've handed out about 30 of these posters around the different kids, which are now in elementary schools, I can only imagine, throughout the state of Alabama after they come in through here. And you see just some other things that we do sort of in our clinic is this is another hemorrhagic bulleye. This is Chris Green. I don't know if anyone knows him. He's one of our ED physicians. So I was in clinic and just sort of the follow-up in the next couple of months. Again, had a great outcome. This is another catching clinic. This is someone that actually showed up actually last October. He was actually seen in one of the St. Vincent's hospitals, discharged after a timber rattlesnake bite, came in a week later, had this bruising. We checked some labs on him, and he was in floor systemic coagulopathy, had an INR greater than 11, no fibrinogen in all his system, so we readmitted him. We're also seeing just some weird neurological complications that come out in our clinic. So we took that success of our clinic, and we got a lot of really positive publicity about it. Now, it doesn't matter what hospital people go to, we're still going to offer them the follow-up. If they do show up to UAB or children's, it does give me the opportunity to do better measurements, and then we can continue those measurements over in a clinic. So that is sort of a sort of plug, if it's possible to get someone to UAB or children's. We also, though, started this year is looked back at our own data and realized, what are we doing with copperhead bites? Because most copperhead bites, if we can get early antivenom in them, and copperhead bites, again, make up, between 80 and 85% of our bites year after year after year. If we get early antivenom in them, and early antivenom is somewhere in that 8 to 12 hour mark post-envenomation, so it's not like a, stroke alert, we're fairly sort of lax what we call early, is we found out it's like, hey, we're actually having really good outcomes. And it's really unusual for us to have to give more antivenom. Standard of care across the country is that all these snake bites get admitted. And so we looked at our own program. It's like, well, our bed situation is atrocious. I think everyone knows that. can we actually develop a program where we actually do not admit snake bites, particularly if they show up at UAB? And so starting this year is we actually created, again, I have more propaganda here if anyone's interested, this is actually our infusion clinic snake bite program. And so this year what we're done, and we started piloting it, so far it's been actually very successful, that if you show up and, with a copperhead or cottonmouth bite, we get you early antivenom, and presuming that, they can still ambulate afterwards, which most snake bites can, we give them some crutches and some pain medicine, and then presuming they had their own transportation, then they actually have a guaranteed spot at our Kirkland clinic, which is our big outpatient clinic, in our infusion clinic at 8 a.m. the next morning. So we give them just an antivenom, send them home, let them shower, and then tell them to report back at 8 a.m. At 8 a.m., we actually repeat labs and do Q1 hour measurements as well. And we are the first program in the entire country that's actually moved antivenom from an inpatient formulary to an outpatient formulary, which means that I actually have the ability, if I want to give more antivenom in our outpatient clinic, as we can. And so the idea behind this program is, hey, how can we continue to improve on sort of systemic or a system-wide approach to treating snake bites? Can we reduce inpatient admission while increasing access to our snake bite program? And I say our snake bite program because I go and see all these patients, but what I was trying to emphasize before is there are so many people beyond me that are actually involved in this. Again, pharmacists, physical therapists, wound care physicians, now the clinic staff at our infusion clinic. And the patient feedback we're actually getting from piloting this year has been overwhelmingly positive, because patients get to go home, they get a shower, they know that we actually watch them from 8 a.m. to noon, and we do Q1 hour measurements. At that noon spot there's actually a decision that's made. If they've met our discharge criteria, and some of this propaganda up here, if anyone wants to talk afterwards, I can show you what that means, is we let them go home and they're given an appointment follow-up with us in a week in our wound care clinic. If they do not meet those discharge criteria, is then we transition them over to inpatient, and then they just become a inpatient admission, which they would have been anyways. So far, we have not converted anyone over to an inpatient admission. We've taken everyone that's shown up and successfully kept them out of the hospital. And I know we're having great outcomes because if I actually get to talk to people in person, they're way more likely to show up to my clinic. If we send them that fax that the Poison Center does, our clinic sort of arrival times or success rate falls up pretty precipitously. And this is sort of why I wanted to come talk to you guys to just let you know we actually have this new program out there. That if you have a snake bite and you're trying to decide where to take them, I would at least consider, I know it can be a little bit farther, but getting either children's or to UAB. Children's still has plenty of beds. We still admit all of our kids there. In the future, we may extend this pilot program over there. But for adult snake bites, is now we actually have this ability to reduce inpatient admissions, increase access to really sort of our very interdisciplinary professional program as well. And we're having great outcomes so far. And that's really, this is just, by the way, some blatant propaganda that we've gotten published about us. This is sort of clickbait. This woman that got envenomated by copperhead last year, right before her wedding. And then she showed up to our clinic. We really did not do anything for her, but her leg got better. And then she called AL.com and said she nearly lost her leg, but somehow we salvaged it. I think this is my just general healing hand and told her she's gonna be okay, was how I salvaged her leg. But it's just some like blatant clickbait that we've gotten from it, but it's just some good positive publicity. And I just want to go ahead and end right there. I took this picture actually in Taiwan. I was hiking around. I did not really need the English translation below it. I got the gist of what they're trying to say. I was brave enough for maybe 3 seconds to snap this photo before I turned the other direction and hightailed it out of there. All right. Thanks so much for having you guys. If anyone has any questions afterwards, happy to talk about what I see.
Yeah, hey Doc, we got a few questions that came in online. Let's see if you could address them. So one is, if a tourniquet's been applied before arrival, should we remove it or leave it as EMS providers?
Please absolutely remove that tourniquet as quick as possible. In the United States, there's no role for tourniquet application, and we do see some bad outcomes when the tourniquet's sort of on there for a prolonged period of time. Yeah, take off tourniquet and take off ice.
So we actually had a couple of people have called in under the same kind of theme, which is, hey, we occasionally encounter people in the Birmingham area out on calls who have exotic venomous and non-venomous snakes from other countries. So is UAB capable of treating those patients if they get bit? I understand it's a really broad question, but I think the root of that question is does crowfab work if they get bit by a gaboon viper or some other exotic venomous snake?
That's actually a great question. And I got to tell you, in my toxicology role, there's two things that keep me awake at night just because we're unprepared for it. Number one is a aminophylliotes mushroom ingestion, which causes fulminant hepatic failure. And then the other thing is exotic snake bites. Crowfab and our other antivip do not work on those at all. There's this rumor out there among people that own exotic snakes, which are supposed to be illegal in Alabama. However, I worry about this enough. I joined all these like Facebook groups. I know that people are actively just selling them in Alabama. It sounds like people are getting a lot of calls about it. There's this rumor that we can easily get exotic snake antivenom from other zoos around the country. That is not true at all. I really worry when we get exotic snake bites to UAB. In fact, right now our plan is try to get them to either Jacksonville or Emory. The reason for that is because Emory just has, the Atlanta Zoo. They have a lot of more exotic snakes, and they have better sort of access to antivenom, exotic antivenom, particularly if that snake is already at the Atlanta Zoo. The Birmingham Zoo does not carry any exotic or any non-native venomous snakes. So the Birmingham Zoo in this scenario is actually of no help to us. So we are unprepared, despite for years of my life trying to see if we could get this fixed. And no, our best plan is actually get them to another state that can probably better take care of them. Yes. Yes. They do. I don't know if everyone can hear that. So the question is about Venom 1 in Miami, which probably a lot of people here know Benabo sort of runs that. Our issues are not getting the antivenom. I can get someone to fly it. Number one, it's getting it out through Alabama state laws. They're going to let us do it. It's a non-formulary antivenom that's not already been approved at UAB, and Alabama laws are not protective about it. Number three is who's going to pay for that antivenom? It turns out insurance will not reimburse exotic antivenom. So right now it's incredibly expensive, and you have to pay for it up front to Venom 1. So it's the logistics of getting exotic antivenom to us it's inordinately complicated. And this is a great question because I want people to understand it. It's not just as easy as getting the antivenom and then hanging at the bedside. There are just tons of rules and regulations and financial implications that I've been worrying about this for years and have so many meetings, and we have just like not made any progress with it. Yeah, well, I mean, none of these antivenoms are actually even FDA approved. You all have to get like an emergency FDA approval to give it, because none of these are already previously FDA approved just to administer the antivenom. So hospitals like Emory that are right next to the Atlanta Zoo already have that IND, that emergency authorization for the antivenoms they have. We do not have that because Birmingham Zoo doesn't have any of those. I mean, these are the antivenoms, the exotic antivenoms themselves are also really dangerous. They do not go through this purification process. They have a very high rate of anaphylactic reaction, which is why these rules, regulations exist actually really for patient protection.
Very good. Hey, Doc, we got another question here. Any bleeding complications that we should consider in the pre-hospital setting for patients that are on blood thinners and presumably also victims of snake bite?
So there's not anything different you're going to do. We see just with as ubiquitous as blood thinners are, we see actually a fair number that come in after a snake bite. We treat them the same with antivenom. Obviously, if they're having signs of bleeding, it's fine to go ahead and put some compression on those bites. It's very rare to get an arterial bite. So even if it, if they are having a lot of venous bleeding, if you can, I would err on the side of just putting direct compression over putting a tourniquet on them.
Gotcha. I think there's a couple of related comments asking about any role of TXA in snake bites.
Right now, no. This is not something that's been universally studied. And unlike most bleeding complications, it's once we get antivenom in them, it actually reverses the bleeding complication of the stink bite reverses pretty quickly. So it's not like if someone's in sort of hemorrhagic shock and they have this ongoing bleeding that's just unable to stop. Is once we get the antivenom, is we'll take care of the problem. So I think it's one of the reasons why we're sort of shying away from TXA right now. Other things I hear a lot about is, what's the role of like cryoprecipitate, what's the role of FFP. We really say is, our first line therapy is still just going to be get them to a facility that can give sort of rapid antivenom.
Gotcha. And then we have a kind of a big group of comments and questions that are all related to EMS operations about prioritizing transport to UAB or children's with a snake bite. Dr. Ferguson might want to address that. I would say my opinion on that is if you're in the greater Birmingham region, you have a snake bite that it seems to be clinically significant, you just go to UAB or children's, pass up the other places. What do you think, Doc?
Yeah, I can't tell you to take somebody to a hospital, but I would say make sure the patient has been well informed and they're aware that the snake bite treatment area is at UAB or children's, and I think they'll make that decision for you. So, I mean, obviously definitive care for this is at UAB or children's. So my advice is take them there, but I cannot force you to take them there.
And so we've also got folks asking, as an EMS provider, do our normal protocols work well for snake bites in the areas as shock treatment, airway pain management? That's kind of related, I think, to what we're talking about there. So, and then the question persists, do all hospitals have at least one dose of antivenom? And I think our answer to that is a resounding no, that is not true. Is that correct?
Actually, most hospitals in Alabama, in fact, if you asked me a month ago, I would say all hospitals in Alabama have enough antivenom to at least stabilize the patient before they get them out transferred. We have had in the last month, we've had 2 hospitals that popped up. We found out did not have any antivenom. However, hospitals may have enough antivenom to initially stabilize them. They may not have enough to continue to treat them, and it is difficult for these hospitals. We're finding out to transfer them a lot of the times.
Very good. Thank you, Dr. Rushton. It's a great lecture. It's always a very popular topic. If you're here in the room locally and you haven't already done so, please scan the QR code you'll see on the flyers and fill out our attendance form, even if you don't need the CEUs. If you're online with us, there's a link to the attendance form in the Q&A section, which wasn't working at the beginning of the meeting for some reason, but now it seems to be working fine. You can do that. The password for the attendance form is snake for today. We're going to take about a 5 or 6 minute break, and we'll be back with Dr. Anderson, who's going to talk about chest and extremity trauma. So everybody take a break and stretch your legs, and we'll be back in about 5.
All right, good morning, everybody. Thank you for being here. My name is Jared Anderson. I'm one of the emergency medicine residents at UAB. My talk may not be quite as exciting as Dr. Rushton's was about snakes, but I do have some good pictures of trauma and a few videos, so hopefully it's not too bad. And I'm sure this is something that you're all pretty familiar with. You know, UAB is one of the busiest trauma centers in the United States, and we see an overwhelming amount of penetrating trauma from gunshot wounds, stabbings, and those things. So hopefully a lot of this is review, but hopefully there's some new things you can also take away from it. There's a lot of trauma that can happen in the chest and on the extremities, so I'm going to try to rush through this as fast as I can so we can finish on time. But if you have any questions, don't hesitate to stop me along the process. Okay, well, I'm going to skip through that slide. I'm sure you guys are all familiar with graphic images, but just FYI. And so just to start, you know, the textbook approach to trauma is the ABCs: airway, breathing, circulation, disability, exposure. But what does that actually mean in practice? And so what we really do is when you get on scene, first assessing for massive bleeding, and if you see that, to stop that. And then you go on to your airway and you're asking yourself, is this patient protecting their airway? Do they have a bunch of secretions, vomit, blood, severe facial trauma? And then what do you need to do about it? For breathing, one, are they breathing? Hopefully so. Always make sure if you have a stethoscope to check for bilateral breath sounds, and then ask yourself, does this patient need supplemental oxygen? And if so, what kind? Can you get by with nasal cannula? Do you need to use non-rebreather, etc.? Circulation, the questions you want to ask yourself is, what are their vital signs? What's their heart rate and their blood pressure? And can we get some type of access? Will that be IV access, IO access, whatever you can? because if their heart rate or their blood pressure is abnormal, things we need to do to fix that unfortunately require some form of access in the vast majority of cases. For disability, you're going to ask yourself, what is their neurologic status? Can you calculate a quick GCS? Outside of the setting of trauma, most often in medical patients, you also want to get your glucose here, as that's a key thing that can cause altered mental status. And then for exposure or environment, ask yourself, am I missing anything else? May not see anything on the front, they might be closed. Maybe they have a gunshot wound to the back, a stab wound to the back, anything to that effect that we might be missing that could potentially explain what we're seeing. So we'll start with chest trauma. We're going to approach this from a primary survey and then a secondary survey. That primary survey being those immediately life-threatening injuries. We'll kind of work through airway, breathing, circulation, and then talk about secondary surveys or things that can be potentially life-threatening depending on what they are and how quickly they're identified and treated. So the first one is an airway obstruction. Oftentimes we think about, a little kid who swallowed a grape or a toy, but this can be very common in trauma. It can not necessarily from a foreign body object, although it can be, but also if their mouth is full of blood or vomit, or if they have severe facial trauma, or if they have a pneumothorax, all those things can distort the airway anatomy, leading to an obstruction. And so the things you see, the clinical signs are going to be those things of air hunger. They're using accessory muscle use. They have a stridor. They have voice change. They're unable to speak. You might feel significant crepitus around their trachea. And so you can see here some pretty severe examples of facial trauma. I for sure would not want to have to intubate these patients. I really don't know how they intubated that one on the middle one there. But it doesn't just have to be things you can physically see. Someone can get punched in the throat and look fine, but have a large hematoma next to their trachea that's going to distort their anatomy, causing airway compromise. And so it may not always be things that are immediately visible. One of the things that's pictured in one of these images is contraindicated actually in the setting of severe facial trauma, one of the airway adjuncts. So that nasal airway, we really do not prefer to use those in the setting of trauma, especially severe facial trauma, with the concern that you can put those straight into patient's brain, as there's case reports and CT imagings that confirm that is a very possible reality. When you get patients like this, they're obviously terrifying. Don't forget to go back to the basics, as Dr. Ferguson loves to talk about. Throw a nasal cannula on them at 15 liters. If you have a second option, also crank it to 15 liters. Bag them, non-rebreather. Try to get as much passive oxygenation as you can, because this is obviously a very difficult airway to approach. So you guys are all pretty familiar with clearing the airway, doing everything you can, including up to intubation if you're allowed to do so. Then what do we do if we can't oxygenate, we can't ventilate, we can't intubate? And that would be a surgical cricothyrotomy. And so if you go through critical care paramedic training, this is something you can be credentialed to do. But if we can't go through route A, we go through B instead, through the middle of the neck. Kind of the landmarks there is you can feel on yourself, you feel that first large protuberance is your thyroid cartilage. And then right below that, you feel a little bit of a give, and that is your cricothyroid membrane. So what we do is we make a vertical incision in the neck, spread it, and then you feel for that cricothyroid membrane and make a stab incision with a scalpel, thread a bougie through, and then a 6-0 ET tube over the top of that. And then you blow up that tube and you ventilate them that way. And so that's obviously a temporizing measure. And then those patients, as soon as they're stabilized, go to the OR for formalization of a tracheostomy. The next injury or injuries to the trachobronchial tree, which includes the larynx, the trachea, and the major bronchi of the lungs. Oftentimes these injuries are fatal on scene, probably before you guys even get there, because you can't adequately oxygenate or ventilate yourself if you have a large injury to your trachobronchial tree. Oftentimes these are from penetrating trauma of a gunshot wound or a bullet that grazes, shears, or tears some part of the trachea or one of the large bronchi, but can also be from severe injuries to the chest, blast injuries, major blunt trauma. Even if these patients make it to the hospital, most of the time they will ultimately die, because let's say you do have a laceration in your trachea and we intubate you, we're still probably blowing a ton of air out through that defect. And the only way to truly repair that is to open the chest and to suture that closed or repair it, which we can't do in the immediate effect. And so oftentimes these patients unfortunately do not make it. Most of the injuries that do occur in about 1 inch proximal or distal to the carina, which is where the trachea splits into that left and right main bronchi. A lot of the things you're going to see with this are similar. A lot of airway compromise, signs of air hunger, cyanosis, respiratory distress. They can obviously develop tension, pneumothorax physiology, as well as a ton of subcutaneous emphysema and crepitus. I don't know if you guys have ever felt crepitus before. I'm sure a lot of you have, but if you haven't, imagine pushing down on a Rice Krispie treat and feeling that kind of give and pop under your fingers. That's what it feels like. On the CT image, the top of the screen is the anterior, the chest, the back is the bottom of the screen is the patient's back, and you can see all this gray tissues, what it normally looks like. On the front of their chest, you see all that black, and that is air. And you can see they are intubated by this little tube in the center of their chest right there, but you can see all the black escaping outside of around that of air just leaking out everywhere. The next one is something that is much more common, and those are tension pneumothorax. And so that's when you have a one-way valve due to an injury that allows air into the chest, but that it cannot escape. So as that air continues to build up, you get all these signs of respiratory distress, which we've already talked about. Some of the textbook or test answers, that tracheal deviation, you might see their veins in their neck really popping out from compression and not being able to flow down to the heart. What happens is as you get more and more pressure on that side, it pushes the mediastinal structures, the heart and the great vessels, to the opposite side, and that compresses the other lung. And what happens, particularly when it compresses the heart and those great vessels, is it decreases the blood flow that is returning to the heart, which subsequently decreases the amount of blood the heart can pump out, and ultimately will lead to cardiac arrest if it's not rapidly corrected. The treatment is a needle decompression. For you guys in the field, in the hospital, we can do finger thoracostomy or tube thoracostomy, putting in a chest tube. Just to kind of highlight the key points of needle decompression in terms of the anatomic locations that you can perform that. It's the second intercostal space in the mid-clavicular line, which is what Dr. Ferguson prefers you guys do. As when I was preparing this talk, I came across a study which looked at placement of the needle decompression, the second intercostal space, by board-certified emergency physicians, and they found that the vast majority of them placed it too medially, too close to the center. And obviously, if you do that, you run the risk of hitting the heart or the great vessels. And so don't forget that it's in the mid-clavicular line, which the clavicle does not end in the middle of your chest. It ends more to the side. So it's high and much more lateral than you probably think. So avoid placing it too medially, because you can injure the heart or the great vessels there, and you're not going to resolve the tension pneumothorax. The other location is in the fifth intercostal space along the mid-axillary line, or just anterior to the mid-axillary line, and importantly along the inframammary crease, not necessarily the nipple line. It's particularly important in females. And so here's your location for that second intercostal space. Again, it's more lateral than you think in that mid-clavicular line. And then for that fifth intercostal space, again, the inframammary crease, not necessarily the nipple line. In the hospital, what we do if we have a patient with pneumothorax is we make an incision in that fifth intercostal space. We push and puncture through the pleura, insert a finger and kind of sweep to make sure we can feel the lung, and then insert a tube in that and connect it to suction to pull out all of that air. Same thing is done for a large hemothorax or blood collection in the chest. You can also have an open pneumothorax where there is an obvious defect in the chest wall, oftentimes called a sucking chest wound. When I was reading about this, once that defect kind of gets to about 2/3 the size of the trachea, just through the mechanics of air physics, which I have really no desire to look about or talk about, the air will preferentially enter the pleural space or the chest and not escape out. So then it can lead to that tension physiology if not corrected. The treatment for this in a pre-hospital setting is a 3-sided occlusive dressing. If you occlude all 4 sides, it can result in tension physiology. So a 3-sided occlusive dressing, which will allow for people, but it's pretty traumatic. You can see that you might have to get a little bit creative about how to cover some of these really large wounds just to the best you can. Next is massive hemothorax, which is the rapid accumulation. The key word there is rapid. Your body's really good at compensating over chronic periods or long periods of time. But if you have the rapid accumulation of large amount of blood, by definition, greater than 1.5 liters in the chest wall, that can obviously lead to acute hemorrhagic shock. The most common cause is from penetrating injury to the chest. You can also have it from severe blunt trauma. And here you're also going to see those signs of respiratory distress. You're going to hear decreased breath sounds, all the indications that are similar to a pneumothorax. And then you're going to see signs of hemorrhagic shock with that increase in heart rate, that decrease in blood pressure. And the treatment is, for you guys, blood resuscitation or fluid resuscitation if you don't have access to blood. And then once they get to the hospital, we can do a finger or tube thoracostomy to remove that blood. You can do a needle decompression. It's just not going to adequately drain that blood out. So unfortunately, this is not something that is easily treated in the field. Here are some injuries. I've actually seen a patient like that. It's not that patient, but on the left there, that Birmingham Fire brought in who ran into a chain link fence in a car accident, had a massive hemothorax and put in a chest tube and had significant blood output. Oftentimes, patients with massive hemothorax will go straight to the OR to have whatever is bleeding inside their chest surgically corrected. Another one is cardiac tamponade. So again, that is when you have compression of the heart by a rapid accumulation of fluid in the pericardium. It can be even very small amounts, 20, 30 mLs of blood in the pericardium can be enough to compress the heart to prevent it from functioning normally. So the pericardium is the sac that covers the heart. The best analogy I can think of is like a Glad freezer bag. That type of strength is what the pericardium is. You can't, not the great value brain, you can't push your finger through it. So as blood builds up in that compartment, there's nowhere for it to go. So it compresses on the heart, again, decreasing the amount of blood that can return to the heart and decreasing the amount of blood that the heart can push out. So this will ultimately lead to cardiac arrest if not rapidly corrected. How we correct it is you either open the chest and cut it open, or you put a needle in and drain it, which I'll show you in just a second. In the field, guys obviously don't have those options. Even if I was in the field, there's nothing really I can do about it. You can give boluses of fluid and or blood, and if you give a strong or a large enough bolus, it can sometimes push open against the pressure enough in the ventricles to allow some, although limited, blood flow out of the heart. So that's kind of a last temporizing measure, is giving a bolus of some type of fluid or blood to hopefully push open those compartments to allow some escape. Here are some post-mortem pictures. So you can see in that small picture on the bottom, they have cut open the pericardium and you can see all of that blood surrounding the heart. And then over on the right side of the screen, that is coagulated blood that unfortunately cannot be drained with the needle. In the hospital and emergency situations, we can do a pericardiocentesis where you put a needle through the chest, most commonly from the xiphoid process, and angle it over towards their left shoulders, and you just advance, withdrawing the whole time until you get blood return. The one on the right is just another technique where you go through the rib spaces. And then just to show you guys a cool video, this is what a post-mortem cardiac tamponade actually looks like. So this heart's been removed from the person's body, and they're going to cut open the pericardium there. And you'll see why this can be so problematic, is this person has a huge amount of blood that is coagulated around their heart, completely preventing the heart from being able to squeeze or function at all. The next thing is traumatic cardiac arrest. Again, oftentimes from penetrating injury to the chest, can definitely happen from blunt trauma as well. The reason I mention this is, unfortunately, there's nothing you can really do about it in the field besides do your regular ACLS protocols by protecting the airway, doing chest compressions. I would say that in any patient who is in traumatic cardiac arrest from any type of injury, whether that be blunt trauma or penetrating trauma to the chest, you should perform bilateral needle decompression, because if it is from a pneumothorax, that's a quick fix that could potentially save that patient's life. Most of the time it's due to hemorrhagic shock, and that's not going to have a huge effect, but you're not going to hurt them if they are dead. The reason I put this in here is that if you bring a patient into the hospital in traumatic cardiac arrest, particularly UAB, you'll notice the first thing we ask is, how long has the patient been down? And the reason we want to know that so quickly is it changes whether or not and thoracotomy, a resuscitative or ED thoracotomy, is indicated in those patients. It depends on your center of kind of what their guidelines are. Some places will never do a thoracotomy on any blunt trauma because the risk of or the rate of survival after this is like less than 3%. Most time it's best for penetrating trauma. But at UAB, if there's blunt trauma and they're in cardiac arrest and it's less than 5 minutes of CPR, depending on the trauma surgeon, oftentimes we will open the chest. If it's a penetrating trauma to the thorax, if it's less than 15 minutes of cardiac arrest, we'll likely open the chest. If it's penetrating trauma that's extrathoracic to the leg, something to that effect, it's just that 5-minute window. But what we do is you make a large incision from the kind of xiphoid process into the sternum all the way down to the bed on the left side. You put these rib spreaders on this left picture and you open the chest. And when you open the chest, you first you're going to identify the heart, kind of move the lung out of the way, identify the heart, and you're going to open the pericardium. So we cut open the pericardium to release a potential cardiac tamponade if that was the mechanism. If you see a defect in the heart, like a gunshot wound, you can quickly suture that, staple it, put a Foley in there, something to blow up to prevent that blood from continuing to escape. You can suture a lung laceration if you see that, like on that picture on the right. And then we cross-clamp the aorta to maximize coronary and cerebral perfusion. So when you cross-clamp the aorta about the level of the diaphragm, it only perfuses things above that, with our goal to perfuse the heart and the brain. Sometimes if you open the left chest and you don't see any injury, we extend that incision all the way across the right, cutting through the sternum, and that is that picture on the right, opening their chest like a car hood, and that's called a clamshell thoracotomy. We're pretty aggressive about doing these at UAB, but again, the survival, I've never seen a patient actually survive. I've seen them survive to the OR, but I've never seen them survive to discharge. Okay, so those were the kind of immediate life-threatening injuries of the chest. Now we're going to talk about some secondary injuries. So one is flail chest. So when you have fractures of 2 ribs in 2 adjacent places and it causes paradoxical movement, I'll show you a video of that in just a second. The immediate treatment is just supplemental O2 and pain control. It looks very uncomfortable. I'm sure it is. It looks scary. Don't let that distract you. Just go back to the basics, the ABCDEs of trauma. Definitively, these patients may require surgical rib plating or fixation depending on how bad the injury is. I don't know what happened to this guy, but this looks quite uncomfortable. So you get that paradoxical movement of normally when you breathe in, the chest wall moves out to let air in, but that segment is going to push in. And when you breathe out, normally the chest gets smaller, that segment's going to pop out. Okay, so it makes it very painful, makes it difficult to breathe, things you would expect. Going along those lines is pulmonary contusion. So most people who are in car accidents, anything like that, you can get a bruise anywhere, including to the lung. So what happens when you get that bruise is blood fills that area, edema fills that area. Again, treatment both pre-hospital and in the hospital is just symptomatic care with supplemental O2 and pain control. The reason it's so important is that these don't develop immediately. They develop over time. And particularly in older patients, they get these large pulmonary contusions. It's very painful to take a deep breath, so they start taking shallow breaths, which leads to more accumulation of fluid, which increases their risk of pneumonia and makes them hypoxic, and they get septic from this type of injury requiring intubation. And so it's something we don't think about as being a, quote, sexy trauma injury, but it is something that can cause a lot of morbidity and even mortality if we don't aggressively treat it. That's just a post-mortem picture of actually what a pulmonary contusion looks like. You can see that at the bottom, that healthy pink tissue, and at the top, that clearly bruised lung. You can also have blunt cardiac injury from direct blow to the myocardium or the heart itself, most oftentimes caused with sudden car accidents where someone's chest is slammed into the steering wheel. Also happened in athletes if they get hit in the chest by a baseball, or in football. That's bottom pictures from the Damar Hamlin case. But it can cause a lot of chest discomfort. And if you put these patients on a monitor, you may see unexplained sinus tach. You may see a lot of PVCs. You may see this new arrhythmia, atrial fibrillation, bundle branch blocks, all of those things. The consequences of these injuries is that it can cause a myocardial contusion, which can cause a lot of downstream effects. It can truly rupture the wall of the heart It can cause coronary dissections and thrombosis, as well as valvular disruption. So the treatment of this varies depending on exactly what the consequence of that direct blow is, but EKG, telemetry, troponins, coronary artery dissection and coronary artery thrombosis oftentimes will look like a STEMI on EKG because both of those prevent adequate blood flow to the heart itself. This is an example of a cardiac free wall rupture. And I also just wanted to mention something you may have heard in the news called commotio cordis. And that is when you have that blunt injury, blunt hit to the chest. It's the most common cause of death in young athletes while playing sports. And they believe this is what happened actually to Damar Hamlin. And so what happens in this repolarization period, right about the T wave, if you have a direct blow to the chest, it's similar to getting defibrillated, and it can send you into ventricular fibrillation, which obviously needs to be defibrillated to get you out of that. Next, we have traumatic aortic disruption. That is when you have a direct injury to the aorta itself caused by sudden changes in motion. Shearing injuries can twist it, oftentimes from significant MVCs or falls from great distances. It's difficult to clinically diagnose this without imaging. If there's a rupture, oftentimes these patients die in the field probably before you even get to them, but you just have a high index of suspicion based on their mechanism of injury that this could potentially be one of the things they're suffering from. Treatment is by, or diagnosis is chest x-ray or CT imaging, and then it's surgical repair if they survive. I'm going to show you, you can see that arrow right there is pointing to something called the ligamentum arteriosum, which is a remnant of fetal circulation that attaches the pulmonary artery to the aorta. And if you have sudden changes in directions from going from 80 miles an hour to 0 in a car accident, it can shear off that ligament and cause disruption, leading to a dissection. So this is a transection of the great vessels of the heart. So that left subclavian, the left common carotid, and the right brachiocephalic, which supply blood to the arms and the head. What happens is arteries are lined by 3 inner layers, and you can have a dissection where blood flow normally flows through that center layer, but it breaks off into one of those other chambers. And as that blood builds up, it pushes on the main central area, leading to decreased blood flow. So this is what a dissection is. It's obviously of those great vessels, but even an abdominal aortic dissection, thoracic dissection, this is what the same physiology looks like. You can also have traumatic diaphragmatic injury, most time from blunt trauma, where you actually have rupture of your diaphragm, most commonly on the left, which leads to all of those abdominal contents, your stomach and bowel getting pushed up into the chest. So I've seen this on x-rays in the trauma bay. Patient comes in, they have decreased breath sounds. You think they might have a pneumothorax, they might be hypoxic, you may have needle decompressed, which is absolutely reasonable. And then we get a chest x-ray and we see all of these abdominal contents up into the chest wall. So you're gonna have those same signs and symptoms of a pneumothorax, maybe some nausea and vomiting as well. Depending on the extent of the injury, it may require surgical repair, depending on how much is displaced. So on this left here, that bottom line is my best attempt to draw the outline of the diaphragm. And you can see on the left side of this patient's chest where that arrow is, there's displacement of the stomach up into the chest wall. And then on the right, this is a post-mortem picture showing that you can see at the top, you can see the trachea, the ribs cut in half. You can see the heart is deviated to the patient's right. See that lung is very collapsed and pushed superiorly, and then you can see a large stomach and bowel contents that have been pushed up into the abdominal wall. You can also have this in non-trauma. A lot of older people with like a hiatal hernia can have where these contents will slide up. Again, there's no way for you to know in the field, but this would be a not ideal candidate to put in a lateral or fifth intercostal space. Needle decompression might decompress some stomach contents, but you're probably not going to decompress the air that's causing their pneumothorax. But again, trauma is unpredictable and you don't always have the answers immediately available to you. So next we'll move on to the extremity injuries. First being the life-threatening major arterial hemorrhage and traumatic amputation. Put these pictures up here not to go through all the arteries and veins of the extremities, but to show you how vascular they are. And those are quite large arteries and veins. They bleed a lot, as you guys are very well aware. And just signs of an ischemic extremity might indicate to you that they have some type of vascular or venous injury going on, a cold, pale extremity. It might be pulseless if it's a complete occlusion. Typically, this is a later finding, but skin modeling. They are typically extremely painful, even to light touch. And if it's a gunshot wound or like a big femur fracture that's disrupted an artery, you may see a hematoma forming underneath the skin, continuous swelling while you're on scene and transporting that patient to the hospital. So traumatic amputations, we've seen several of these brought into UAB. Just kind of an approach to these, because oftentimes you get the scene, you see this, it's a distracting injury, it's very scary, it makes you want to deviate from your CABCs, but unless this thing is massively bleeding, remember, massive exsanguination, airway, breathing, circulation, disability, exposure, then let's address the extremity. But you get there, this is massively bleeding, kind of what should be your general approach to a traumatic amputation? Mine would be immediately placing a tourniquet on that extremity. It's pretty obvious. But what if it's still bleeding? I would put a second tourniquet on, more proximal than the first. And then if it's still bleeding after that, maybe some venous ooze, you can look at the wound itself and see if there's a particular area. Maybe you see a blood vessel or you see a vein. That's not the whole extremity's bleeding, but that one area. And then you can try direct isolated pressure to that one area and hopefully stop it until you get to the hospital. Another one that is probably people don't think about can be immediately life-threatening, but bilateral femur fractures. And so the average adult male can support up to 30 times their adult weight. So if that makes you feel bad about your squatting weight, it should, or about 6,000 pounds of compressive force. And so all that to say, the femurs are very, very strong. They're the strongest bone in the body. And so if someone has one femur fracture, let alone two femur fractures, have very high suspicion that there are other injuries as well. There are just some x-rays there of a mid-shaft fracture, and then you can see one intratrochanteric fracture on that greater right side. Pre-hospital treatment, I don't know if all of you guys carry traction splints, but if you have one and you have the time to apply them, they are helpful for controlling blood loss, both external and internal bleeding that you may not be able to readily see, reduce pain, and to prevent further neurovascular injury. Does anybody know a contraindication to placing a traction splint? Yeah, ankle injury or tibial injury. If they have a fracture below the femur, don't want to just pull on that. It's not gonna have the effect you want it to. And I'm sure there are some other ones, but that's a big one. So a quick break from talking about specific pathology to just what are the 6 areas that you can massively bleed out and bleed to death in the body? Think more broadly, like just bodily area. So the bilateral thighs, the chest, the pelvis, abdomen, and then lastly the retroperitoneum, and then obviously the floor. So these are the areas in which you can truly bleed to death. You're not going to bleed to death from blood loss in your brain or your skull. You might die from brain injury, but you're not going to bleed to death from an isolated injury to your brain. But these are the areas that you can lose enough blood in to cause you to die. Next, on the primary survey for extremity injuries, we're talking about crush syndrome. This is important because it can lead to traumatic rhabdomyolysis, which is not something immediately noticeable for you guys, but a downstream effect for the patient is when you have those crush injuries, particularly if it's prolonged or even immediate, you get cell death, and then those cells release all these toxic substances. So when you remove that crushed object, that blood flow comes and rushes in, and it takes all those localized toxins and spreads them to the rest of the body. And that can, one, it results in the release of myoglobin from damaged muscle cells, which goes to the kidney. It clogs it up and can lead to acute kidney failure. You get all this potassium release, which you guys are well familiar with, which can cause bradycardia and cardiac arrest. Get all this calcium, which causes systemic hypocalcemia, can lead to muscle spasms, seizures, cardiac dysrhythmias. Get a lactic acidosis, which can lead to altered mental status, and if they become severely acidotic, can lead to circulatory collapse and cardiac arrest. And then you get all this dysfunctional coagulopathy, one of them leading to disseminated intravascular coagulation, or DIC, aka death is coming, which is this horrible condition where you have at the same time simultaneous clotting and excessive bleeding. So you utilize all your clotting factors, and then you bleed from literally every orifice. If you've ever seen a patient of this, it's quite scary. The signs and symptoms, as you'd expect, someone who has been crushed by some object, whether that be the engine, being entrapped in a car or a large object like a machine. You're going to see this damaged tissue, a lot of edema. You may see those signs of vascular compromise with mottled, blistered, bruised, or pale skin, signs of absent or poor perfusion, and then shock. And then another sign that you guys hopefully are not going to see, hopefully they're not urinating and you see this, but in the hospital, if someone has a crush injury and then has a lot of reddish or brown urine, that is all that myoglobin that has been filtered into the kidneys that they're just peeing out. That's going to end up causing some kidney damage. We treat this really aggressively with fluids, try to wash all of that out. For the secondary survey are some limb-threatening injuries, but not necessarily life-threatening injuries, are open fractures and open joint injuries, something you guys see pretty commonly. They're at very high risk, as you would imagine, for bacterial contamination. And if that's so, not readily washed out and cleaned, it can lead to severe infection, poor healing, and even limited restoration of function of that extremity. For you guys, obviously the basics of trauma care apply, controlling bleeding. If you can splint or immobilize it from preventing any further disruption to blood vessels or nerves, that would be amazing. And then check for a pulse. Obviously, this is not your top priority if the patient has other life-threatening injuries. And then I put on there to remove non-impaled gross contaminants. Obviously, if something's impaled in the wound, don't pull it out. It may cause bleeding. Not here, but back in Oklahoma, where I went to medical school, I saw a patient who came in with an open fracture, and there was part of a plastic fork just sitting in the wound, not impaled, just sitting in there. Those types of things you can pretty easily pick out. And then if you're going through an area where it's very windy, there's a lot of dust, if you can cover it just until you're back in the ambulance or into the hospital, prevent further contamination, that would be ideal. Another one, vascular injuries. These are true medical emergencies where if they're not emergently treated and identified can lead to loss of a limb. And if that limb becomes infected, that can lead to loss of life as well. So signs of non-complete occlusive vascular injury are going to be that coolness. You might see a prolonged capillary refill if you so care to check for that, as well as diminished peripheral pulse. You may not be able to feel it. You may be able to feel it on Doppler, but you may not be able to palpate it. And then occlusive vascular injuries, cold, pale, no pulse. And then a later sign, again, as we mentioned earlier, is that mottling. So you can see that patient's left leg is quite ischemic. Next is compartment syndrome. Something we don't think about is that particularly in the arms and the legs, and truly all throughout the body, but it happens most commonly there, is that muscle groups, there's 4 different muscle groups in the calf. Each one of those muscle groups is surrounded and encapsulated by a thick fibrous layer. Again, think of it like a Glad freezer bag. Those muscles are encased in that. So when you have compartment syndrome from a severe crush injury, from a burn, from a closed fracture, especially a tibial fracture, or even patients who have had a fracture that's then been casted really tightly, it can lead to swelling and edema or injury inside one of those compartments. And as that pressure builds up, again, there's nowhere for it to go, so it compresses the muscle, and then it compresses the nerves and the arteries and the veins that run through that leg, and it can lead to profound injury, which is life-threatening. What typical signs and symptoms you would see is that pain greater than expected or, quote, out of proportion to the exam. Leg might look okay, but you barely touch it and they're screaming out in pain. If you barely move their ankle forward or backwards and they have on passive motion, they have severe pain, that's a red flag. Obviously the leg or the extremity or whatever it is going to feel tense and taut, and they may have some altered sensation or decreased sensation in that extremity. If you do not feel a pulse, that's a late finding indicating this compartment syndrome has been going on for quite a while. This picture on the left is showing the compartments of the leg. The treatment for this in the hospital is a fasciotomy, where they go in and they make an incision on the leg and they actually cut open that compartment to release the pressure. This middle picture here is a transection of a tibia, where you can see the tibia is that top bone and the fibula is down there towards the right. And it's pointing out all the different muscle compartments in this kind of middle back compartment. You can see that muscle has gone from that nice pink red color to this gray brown color, and that is there's so much pressure in that compartment that it compressed the muscle, compressed the nerves, compressed the arteries, leading to lack of blood flow, leading to tissue ischemia, leading to cell death and muscle death. And that has to be surgically removed or it'll become infected and lead to a lot of problems. And then the last slide, just a pearl. Has any of you guys heard of the shock index before? It's something that I personally, in the emergency department, don't bother ever calculating, but I think it's something that can help you identify patients who might look okay, but are really in maybe uncompensated shock. And so the shock index is an indicator of occult shock. It's predominantly used in trauma and hemorrhagic shock, but you can use it in any patient. And it's a simple algorithm, their heart rate divided by their systolic blood pressure. Normal, it should be low. Just think the lower it is, the better. So that 0.5 to 0.7 range. And the higher it gets, their higher risk of death, the higher the risk that they're in some form of uncompensated shock. In the setting of trauma, we obviously worry about hemorrhagic shock. But as I do when I evaluate this in the emergency department, is just keep it simple. Don't worry about the calculations. If a patient's systolic blood pressure, if their heart rate is greater than their systolic blood pressure, that is bad. Right? In a setting of trauma, they're probably bleeding somewhere. Even if they physically look okay, they probably have some form of internal bleeding. So this is definitely true for trauma. It's also true for medical patients. Think about your older patient who their heart rate's 130, but their systolic blood pressure is like 102. You're like, oh, the blood pressure is technically in normal range, but their heart rate should not be that elevated, right? And so if their heart rate is greater than their systolic blood pressure, have some pause. Think this patient has something nefarious going on that you may not be able to see. And then lastly, just to touch on the classes of hemorrhagic shock, this is not intended for you guys to memorize all these findings, but more so to point out that for you to have vital sign abnormalities in the setting of hemorrhagic shock, you have to have lost quite a bit of blood. So you'll see that to even have an elevation in your heart rate from loss of blood, you've had to lose 15 to 30% of your blood volume. For you have a decrease in blood pressure or changes in mental status, again, solely due to blood loss, there's obviously compounding factors. You have to have lost 31 to 40% of your blood volume. And then when you find those patients who are profoundly tachycardic, really hypotensive and altered, they've probably lost greater than 40 to 50%, half of their blood volume. So when you get to the scene and you see these patients that have normal vital signs, realize that we are really behind the ball on resuscitating these patients. And I know that most of you guys do not have access to blood. It's very rare to come by, but ideally these patients would be quickly resuscitated with blood products or whatever you have available, crystalloid, whether it's normal saline or lactated ringers. But just realize we're really behind when we see these types of vital sign abnormalities. And they've had profound blood loss in these settings. So sorry, I know that was a lot and I rushed through it. I want to make sure we finish early for a break and have time for our guests to come in. Does anybody have any questions, comments, concerns about the lecture? All right, well, thank you guys.
Thanks, sir. I wanted to touch on a few things. One, traction splints. The other contraindication I may not have just heard it back here is any kind of hip injury, right? So if they got a broken hip, an acetab fracture, you can't put a traction splint. And how do you know if somebody has a hip injury in the setting of a femur fracture? You get an x-ray, right? Y'all can't do that. So my advice, I'm not a big traction splint guy. I would say that if you need to mobilize that leg, you can put a SAM splint on it. You can secure them to the backboard and use that as a splint. The backboard will not be used as a spinal immobilization at that point, but it's just for splinting, right? Or don't move the leg. But traction splints are kind of going away for the most part, right? So if you bring them in on traction splint, once we do our ABCs in the trauma bay, what are we going to do? We're going to take them off that traction splint and put them in the immobilizer. The other thing that he already stressed, but I'm going to stress it again, tension pneumothorax. The way I would recommend you define that is they have signs and symptoms of a pneumothorax and a mechanism of injury that makes you think they have one. Dude shot in the chest, stabbed in the chest, hit across the chest with a baseball bat. They're working hard, low sats. You think they have a pneumothorax, okay? The next thing for tension is, one, they go into cardiac arrest. That is signs of tension, right? You decompress the affected side. If that doesn't fix it, you decompress the other side. If that doesn't fix it, we're probably not going to save them at that point. The other sign, the other time you would decompress the chest would be they have that pneumothorax we talked about, and they have signs of tension, which would be defined as altered mental status and poor perfusion. Okay, so if they just have a pneumothorax, sats are 80%, they're working hard, and they're texting on their phone, do they get decompressed? No, they got to be altered, okay? People don't appreciate that procedure. They should be altered and almost dying to get that done, okay? We will have a cadaver lab the 29th and 30th of August. It'll be up on Eventbrite, hopefully by today. Okay, and I'll share that on Facebook. That is free Thursday afternoon and all day Friday. You got to sign up. But we'll do chest decompression and IOs. All right. Those are my questions. What you got, Chief?
That's all, guys, as far as content questions. Just wanted to let everybody know that we are going to take just a couple minutes break here, and then we're going to have a great honor of recognizing some providers from Pelham Fire and a surviving cardiac arrest victim. So if you want to stay online and see that, I'd certainly encourage you to do so. The other thing is, if you haven't already done so, please fill out an attendance form for today's class. If you're online, you can find the link in the Q&A feature. If you're here in person, you can scan the QR code that's on the flyers around the room. If none of that works for you, you can send an email to alabamaemschallenge@gmail.com. Doesn't matter what the content is, you'll get an automated reply with a link to the attendance form. The password for the attendance form today is SNAKE, in honor of our first hour lecture from Dr. Rushton. And that's all I got right now. Where we going to be next, Dr.?
Next Wednesday is a bonus because we have to make up. We'll be at Talladega Super Speedway, 9 to 11. We're going to do burn trauma and then cardiac arrest scenarios. And then the next week we're in Prattville. So we got 3 classes this month plus a cadaver lab. So lots of opportunities. Okay.
Yep. Come out and see us. Appreciate everybody that joined us in person and online, and we will see you next time.
Hey, we'll go back online. I'm going to just turn it over to you. I'll let you introduce yourself. If it's okay, or whoever. Yeah. And then I'll challenge guys. I want to give these to them too. So just okay. Like a millennial. Do not. Go back on, sir. All right. I turn it over to you, ma'am. Or you, sir. Sorry.
First.
Well, I know who's in charge, so you're not tricking me.
Thank you, Dr. Ferguson, and thank you to each of you for allowing us to briefly come and share our story. My name's Carrie Dodson. This is my wife, Melissa. Our story starts really with the events that happened on May 15th. And I'll briefly back up and say we had just gotten back into town on a medical trip because we had just gotten all clear on a cancer scan we had just a procedure in July. So we were sort of in a celebratory mood. We went out to an establishment called the Beer Hog in Pelham to play trivia. Now, normally we play trivia on Thursday nights, but this was a Wednesday. We have another set of friends that play over there, and we just decided, let's go out and do that. That afternoon, my wife's, and forgive me, I have no memory of that day. I'm going on secondhand information as relayed to me by my wife and some friends, but I had a headache, which is sort of unusual, laid down, took a nap, was feeling better, and decided, let's go and play trivia. So we were out there about halfway through the event. My wife was standing up listening to the trivia host repeat a question. We were amongst friends, and this other friend of mine, Kim, that was sitting next to me, kept giving me a hard time about answers out loud and giving away the answer to the competing tables around me. But anyway, I reached over to say something to her, and her what she said was, I slurred my words, I slumped over on the table unresponsive. Her attention span was with the trivia host listening to the question, and she called out her name, said Melissa, and looked down and saw me, and she at first thought I was just joking around amongst friends because we had been threatening bodily harm to each other, and she realized it wasn't a joke. I was truly out. So they got me down on the floor, mainly just checking and monitoring, making sure I still had a pulse. I called 911, and then about
can tell you, it felt like 45 minutes before y'all got there, but I think it was minutes, honestly. I think it was minutes, honestly. Yeah. And you know, his recollection of, well, he doesn't have any recollection. That's the one, he has no memory of anything. But for me, because he's a prankster and I thought he was just being goofy, when I turned around and looked at him and he's laying on the table, I immediately said, "Are you being, oh God," because I realized the look on his face, he was not awake. Thankfully, our friend Kim had been through nursing school, and I'll be honest with you, the rest of it's a little bit of a blur. I remember getting him to the ground. How I managed to do that, I have no idea. And then I just started screaming at him to stay with me. And right now, I'm not crying because I'm probably going to lose it. But here, it's hard.
So I know you guys don't always get the kind of positive outcome from your calls, but fortunately, I am a product of your training, your expertise, your dedication, and your devotion. And I just want to recognize Pelham Fire Department, Engine 92, Medic 96, A Shift, Fire Medics Brody Wade, Trey Bagley, Brandon Pekarek, Firefighter Greg Lowry, Captain Brian Underwood, Battalion Chief Philip Lorino for performing their CPR and ALS procedures that gave me the ability to come here and share my story. Yes, go ahead and applaud. We've since this time, I have had to spend a lot of time processing what happened. It came completely out of left field. I had no symptoms prior. I was in cardiac arrest caused by ventricular defib. What I have seen statistically, and Dr. Ferguson has borne us out on this, is about, if that occurs, your survival rate is about 5 to 10%. And in this, of those that survive, many have permanent brain damage as a result. You know, I'm a living testament to your dedication and your devotion. And I just want to say thank you from the bottom of my heart.
Yeah, for me, guys, over and above you saving Art over here, all were so kind to me the whole time while I'm losing it. Well aware that I was losing it. You take this man that I adore, who has been perfectly healthy, and suddenly he's dying. And I did CPR training from several years ago, been through it twice, but when it's your husband to breathe, left me. So I just want to say thank you, not only for obviously saving his life, but understanding where I just wanted to touch him. I just wanted to, and y'all were so kind to me to reassure me as y'all were working on him that, you know, y'all thing. And then when you got him on the gurney, y'all let me, as y'all were putting him in the, and just how kind you, my life was about for that.
That's right. Absolutely. Thank you.
Thank you.
See you again.
I will show you the funny thing that, the funniest thing that I said is looking up, I was screaming at him to stay with me and breathe. And the best thing I ever saw in my life was Brian Underwood's knees down. All I saw was his pants and his shoes, but I knew the paramedics were there. So, and I had no idea who he was until we went back and saw him later at the fire station. But I'm here to tell you that was a happy moment for me because I knew he was there. So thank y'all for being so, you know, well trained and staying on top of it. And, you know, he wouldn't be here without y'all.
This morning, I was just taking a pray.
Thanks for coming out. Appreciate it. All right. Thank you guys.